Hello, and welcome to today's Quickenar, Treating the Caregivers of Older Adults, Essential Basics for Population Health. At this time, I'll turn the floor over to your host, Stacy Hull.
Hello, and welcome to Aligned Quality's Learning and Action Network for improving the identification of depression and alcohol use disorders in primary care. As Aligned Quality's Behavior Task Lead, I would like to extend my appreciation to you for participating in today's learning event and for your commitment to improving the outcomes of patients you serve.
Please remember that Align provides free technical assistance for you and your office staff. We can assist with things such as office flow processes, screening tools, implementations, and referrals. If we can be of assistance, please do not hesitate to reach out. I would like to turn your attention to the depression code slide. These are Medicare reimbursable codes, as well as the alcohol codes. Please use these in your practice. And now it is my pleasure to introduce Dr. Paula Hartmann-Stein. Dr. Hartmann-Stein has previously presented for Aligned Quality on identification of late-life depression in primary care, behavioral activation, and the screening for alcohol misuse in older adults. Recordings of all her presentations are located on the Aligned Quality website at www.alignedquality.org. Dr. Paula Hartmann-Stein is a geropsychologist, healthcare educator, and journalist covering Medicare issues for the National Psychologist newspaper. She has edited 2 books, Enhancing Cognitive Fitness in Adults and Innovative Behavioral Healthcare for Older Adults. Dr. Stein has 30 years of experience in direct patient care settings that include primary care, hospitals, and private practice. She is currently an associate professor of psychiatry at Northeast Ohio Medical University, a senior fellow at the Institute for Lifespan Development and Gerontology at the University of Akron, and faculty in the Integrated Primary Care Certificate Program at the University of Massachusetts Medical School. Active as a national advocate for quality health care since 2007, she currently serves on the Depression in Elder Maltreatment Screen Technical Expert Panels for CMS. Pertinent to today's topic, Dr. Stein was a long-distance caregiver for 8 years for her mother, who had dementia. Dr. Paula, the floor is yours.
Thank you very much, Stacy. I appreciate your introduction. Okay, this afternoon, or morning, whenever you're listening to it, we're going to go over the impact of unpaid caregiving on public health. We will look at some reasons that you should consider evaluating and treating caregivers of frail older adults and other adults with mental health problems. We will identify some strategies to mitigate the stress of the caregiver and also mention when a referral to a mental health specialist, especially somebody in geriatric behavioral health, would be useful. And there are plenty of resources I will be mentioning for family caregivers. Before I begin the rest of this, what is a caregiver? Well, according to researchers, a caregiver refers to people who provide significant oversight and or work for another beyond what is typically done reciprocally between adults. So in addition to the work that the person has to take care of in his or her own life, a caregiver takes responsibility and does some of the work for the life of another person. Now, this has impact throughout the United States, and the CDC says that there are 40 million unpaid caregivers in our country. I read last week the figure was 43 million. And as many as 8.4 million Americans provide care to an adult of a variety of ages who may have an emotional or mental health problem. So, many caregivers are depressed, and in one study of over 5,600 patients who were diagnosed with moderate to advanced dementia, about 1/3 of their caregivers met the criteria for clinical depression. The average age in this study was in the mid-60s, and to no surprise of us in healthcare, most of the caregivers were women, 72% in this study. But this did surprise me, that the caregivers reported spending an average of 89 hours per week in caring for the patient. That's a lot of time. So why should we care about treating depression? Well, one good reason, there's many reasons, but one good reason is that a depressed mood in the caregiver influences the caregiver's health and can correlate with a decline in their own cognitive skills, such as processing speed, that is the amount of time to catch on to information, their ability to attend and concentrate, and visual scanning skills. In everyday life, visual scanning skills are required, for example, in driving. So these cognitive issues these skills are necessary for independent living. So these are the caregivers we're talking about who may have a decline in those areas. Now, I mentioned health. Also, about half of caregivers report worsened physical health due to their responsibilities. So the bottom line here is that depression is common in caregivers. It is associated or correlated with a poor quality of life and is a risk factor for functional decline and death. Now, many people have a sense of gratification for being a caregiver. Even though there's stress involved, there's also meaning. It can provide meaning in life, certainly. And there are 3 levels, or as I say on this slide, circles of caregiver support. The first level, of course, is the immediate family. Second level, extended family, friends, community support, such as what is given by churches, synagogues, and mosques. And then for those of us who are healthcare providers, we're in that 3rd tier or level. So what are the type of interventions that are out there for caregivers to mitigate, decrease the stress? Well, education, of course, very important, and all of us can provide that during our sessions, no matter what our primary services that we're doing with the caregiver. To give education, there are support groups out there, of course. There are individual interventions, medical, social work, care management, psychological. There are family interventions because caregiving affects not just the primary caregiver, but also family around them. And then, of course, there's the level of community interventions that we can see, for example, in calling in adult protective services as one example. So Rosalind Carter Institute has listed what are the characteristics of successful caregiver programs, and I'll just go over them briefly. But one is that if the caregiver has contact with the same helper over time to increase trust, okay? Another one is that the helper needs to be able to deliver specific intervention protocols to follow the need of the patient and the caregiver, and care plans tailored to them. Multi-component interventions can include, again, giving information, helping to build skills, helping to problem solve, and, of course, the emotional counseling aspect of it. And in successful programs, there's a combination of some home visits if it's possible in your particular setting, telephone follow-up, and if it's possible, telehealth technology, of course, a growing area in healthcare today. And the programs that are developed and implemented locally need to have some collaboration among agencies. So what does a caregiver need to understand in regard to information? Well, it helps that they understand something about the cause, the characteristics, the trajectory to expect. What are the common care demands and challenges, as well as services, as well as the effects of the caregiver on the broader family system, what to expect from the greater services that are out there. Now, I want to underscore this, that don't assume that the caregiver is going to ask you for specific help if you are their provider of care. So I advise that you ask the caregiver, what is the toughest aspect of your responsibility to handle? And of course, supporting the person by acknowledging just how tough it can be, because supportive words have power more than perhaps you realize. And ask the person if he or she has taken any time to carve out exercise, hobbies, engagement in hobbies, seeing friends, and encourage these activities. This last point on this one slide, I put it in here directly from what one of my former patients who was a caregiver of her husband said to me. She said that her primary care provider helped a lot by just saying it out loud, right out, to discuss placement. She said that it reduces, these are her words, some of the horror, and it gave her permission to proceed. So just talking, you know, acknowledging the so-called elephant in the room, I suppose, does help. Now, again, practical solutions, such as encouraging the caregiver to seek some time away if possible. And for those who are taking care of people who live with dementia, to suggest what's out there, senior centers, adult day centers, PACE programs, if you have one in your region, program for, that stands for Program for All-Inclusive Care of the Elderly. But as I like to point out when I talk about this, one solution does not fit all. Let me give you an example quickly in my own personal experience. My mother, who was living with dementia, got to the point where she really needed some stimulation other than, you know, sitting in front of the television or napping most of the day. So here I am, this clinical geropsychologist. What do I say to my dad? Well, let's try an adult daycare for my mother. This is what I've always been taught helps. So he said, I don't know, Paula. I don't know if this is going to work with your mother. You know how she is. So it worked for all of 3 days. Why? I should have realized my mother was never a joiner of clubs. She was never in any women's clubs or anything within the church. She was a pretty solitary person all of her adult life. So why would I think that adult day would work for her? It certainly didn't. So as I say, one solution does not fit all, but we as healthcare providers need to give options to the caregivers whom we serve. Now, I like to put it this way. If the family has resources, it is time, and they need more help, and it's time to hire some help in the home. I like to tell the story that the rainy day has come. Quickly, I had a patient I had worked with for about a year, a retired professor from a local university. He had health issues, not so much dementia, some mild cognitive impairment, but mostly health. Well, one day, I'll never forget it, his wife called me and said, my husband really wants to see you, but he can barely walk, but he really is asking for you. I said, I'll go to your house. I was able to do it after my duties were done on a Friday afternoon. It was a dark Friday evening. I'll never forget it. I go in there. I see what she has to deal with physically, and she's in her upper 80s. He's in his early 90s, and I knew him especially very well. This was a gentleman who was very penurious, shall we say. He was a real environmentalist and didn't waste anything. His coat, I think, when I helped him put his coat on one time, it had to be at least 30 to 40 years old. It was coming out at the seams. Anyway, so I sat down after I observed what was going on. I sat down with them and said, look, folks, the rainy day has come. They understood what I meant. They had saved their money. And fortunately, I had a specific referral of a home health care aide. I got her on the phone. The wife talked with her. She started the next day to help with the gentleman's care, and he passed away 10 days later. They got some hospice services in as well, but this caregiver was there every day to be of service. And what the wife said, I heard this later, what the wife said after her husband passed was, we brought Dr. Paula in, who brought in an angel to help Clinton die with dignity. So those kinds of interventions stay with you. So enlist the help of programs such as the Senior Companion Program, if there's one in your area, or through, as I said, local resources such as churches, et cetera. Now, as a provider, realize that caregiving does not end with placement. And if the care recipient lives in a facility, but if the caregiver's health is declining, you need to look a little deeper. And there are resources to make the visit the visit of the caregiver to the person in the facility more pleasant. This is one. It's written by a colleague of mine. He's one of the authors, Cameron J. Camp, called A Different Visit, and it gives some really practical strategies to utilize when people visit those in facilities. I want to give a quick example of how, again, if you're a primary care physician or a nurse and you're working with a patient who is a caregiver, look at their symptoms, and it may give you some clues as to what is needed. I'll never forget this case. I was an intern, and I was working with a rheumatologist, and a new patient came in. He evaluated her. She had a condition, some of you may not have heard this term, I certainly never had before, called aphasia abasia, an inability to walk properly. After his evaluation, there was no clear medical etiology for this. So he said to me, Paula, go talk with this lady, find out what her stressors are. I came back and I said, well, she recently placed her mom in a nursing home, and she visits, she's guilt-ridden, and she visits about 6 days a week. He said, aha, I know what to do. He gets out his prescription pad and he writes to her, Mrs. Jones, you must visit your mother no more than 3 times per week. Your condition is such that it will only worsen if you continue the frequency of your visits. He didn't give her any other explanation. Now, of course, as a psychologist, I think he might have referred her for some therapy, but he chose not to do that. But in this case, that was okay, because I happened to be on his service a month later. What do you know? The aphasia symptoms were totally abated. How about that? Her body was talking to her. It was an unconscious thing. She couldn't verbalize her guilt and the stress of visiting 6-7 days a week. Okay, example of other education, dealing with memory loss. We're going to show you now a short video of a caregiver group.
It's just the idea of not negating the person's reality. People need to feel understood. So if I would have said to my father, Dad, it's ridiculous, there's no washing machine in there, then he would have felt,
But to him there is.
But to him there is. So contradicting his reality, it doesn't make sense.
Right.
What the standard thinking is today is that this part of our brain in which we learn new things and then forget them. That's the hallmark characteristic of dementia. The other circuitry in the brain, this is the thinking, of our emotional responses are not on the same circuits as those of our memory responses. There was a gentleman I used to visit at one of the nursing facilities in Akron, and I worked with him for about 1 to 2 years as he was just entered into an assisted living facility. And we got to be very, very close. He looked forward to my visits. I felt that I did help him adjust and get out of his depression and all this. Anyway, so I play by the rules, so I stopped treating him. But when I would visit the facility, sometimes I'd see him, and I would always speak to him, So I'll never forget this. Now, mind you, I'm in my 50s now. Then I was in my 30s, okay? And he was in his 90s.
Wow.
So one day I went down and I said, well, hello, Mr. Jones. And he said, because he was in a wheelchair,
Okay.
I got down there and he said, I know you. And I said, yes, you do. You do. I've seen you here before. I know you, not here. No. It was, we used to go dancing.
Yeah. Oh, gosh. Oh, jeez.
And so what that is, that's emotional circuitry. He had warm feelings toward me. He vaguely remembered that he had some kind of relationship with me. That's what that was all about.
I don't know if you could have heard that, if you heard that little clip, but it was about how people keep their emotional memory circuitry intact, even when they don't remember facts and various events in their life. All right. Another problem that is common for caregivers who are working with people with memory problems are having annoying, repetitive questions. There is a technique called spaced retrieval, which works only if the questioner has memory loss and wants the information, not if the person is seeking attention. I'm going to go through this very quickly. There is a technique, and one can read it. I have some references about spaced retrieval, but it's basically if the person asks on and on and on, over and over, for example, who sits with us at meals? And the answer is Jim and Susie. Then the caregiver gives the answer and then immediately asks the person, so who sits at dinner with us? And if the person remembers and says it's Jim and Susie, you wait 10 seconds, and then ask the question again. And so you do this over time, several times, until they get it right. And once people keep it in their mind for about 12 minutes, then it's usually there. Okay, I want to go to the slide on stress management for caregivers, and this is a list of strategies that are useful. There's some good evidence for them. Teaching people how to do some simple deep breathing techniques when they're overwhelmed, how to do some what we call mindful relaxation. It's important for the caregiver to have good restorative sleep, spend time in nature, exercise, spending time with pets. Writing their experiences out is also helpful for some people, using spiritual coping and behavioral activation, which means getting the person to be active, both the care recipient and the caregiver. And using support groups. I did a study in 2013 of participants in the community and that I gave a program to over 6 weeks. And the top 4 strategies that they said they were willing to do were to use relaxing breathing, spend time in nature, use some spiritual coping, and also monitoring their own personal level of distress. Okay. Now, the next slide about when to refer to a mental health specialist. Well, if the caregiver's health continues to decline, do consider referring the person and frame it, though, that it's a path to improving their health and well-being with the result of being a better caregiver. It's not for self-centered reasons in any way, shape, or form. Okay, so the next slide on individual interventions. One point I want to make is that sometimes caregivers can easily feel anger because it's easier to be angry than to be sad. So that's just generally the case. Let's go to the next slide about some tips about not talking down to the caregiver as though he or she doesn't know anything about this condition of the recipient of care. But also, don't assume the caregiver understands everything. And one quick example, my father called me one day and said, Paula, your mother's trying to kill me with the way she's making food these days. And I said, oh, Dad, she's not trying to kill you. She just is forgetting how to cook and what to put in the recipes. So that gives you a clue that he really needed some education. And so the point here is that if you are the primary care physician of the care recipient, assess not only the care recipient, but the level of understanding and the ability of the caregiver. And I'm going to end with some thoughts from my colleague Barry Jacobs, who's a psychologist who has written books on caregiving, and his mother recently died, and I quoted him here. Because each family situation is so unique in its history, dynamics, and resources, no self-help blueprint can address each pressing crisis. There is no magic other than the caregiver's creativity. And the last slides that we have here are a number of caregiver resources for you that I hope you will share with your patients. And with that, I will close.
Thank you, Dr. Hartman-Stein, for such an informative and helpful presentation. And thank you, the participants, for joining us. Our next event will be held on July 20th. Dr. Leslie Manson will present on utilizing huddles for care optimization and integrated care. Again, if we can be of assistance, please reach out and enjoy the rest of your day.